Thank you so much for the introduction and for the invitation. I am so thrilled to talk to you guys. And also, I was really happy to put this talk together because I do speak quite a bit about sexual dysfunction in cancer survivors, but I needed, I do have some AYA patients in the music program, but I needed to kind of go back and refresh my own memory. So as you said, I actually started out as a gynecologist and then crossed over into breast surgical oncology. The majority of my practice is breast surgery, but I do have the sexual health after cancer program. So there's not a lot, I'm sure if you've tried to look some things up, there's not a ton of research out there on the best way to treat these patients. So I've been running the music program for 3 years now, and I've learned so much from patients. And so I like to try to give patient feedback in these talks so that everyone can learn what I've learned. So I'm going to talk about different hormonal formulations and brands, but I have no financial disclosures. I don't take any money from any companies regarding music. It's trademarked, but it's just the name for our clinic. I just trademarked the acronym. So I'm going to talk about a couple like case-based studies. So first, a young woman with breast cancer. I'll go through how I talk about moisturizers and lubricants, a young woman with cervical cancer, and how I address painful sex. Sounds like you guys have already talked a little bit about contraception, but I'll just give you some resources that I use. And then libido, like literally the hardest thing to treat out of all of this. And so both non-pharmacologic and pharmacologic options. And then I'll tell you what I don't recommend that I get asked about a lot. So the first case is a young woman with breast cancer. She's 32, recently treated for a triple positive breast cancer, had neoadjuvant chemo and had a great response. And now she's finishing up her Herceptin and Perjeta, and she's getting married. And she's been experiencing these symptoms. She's on an AI and ovarian suppression. She's BRCA and BRCA-like gene negative, and she has a family history of breast cancer, but her mother also had early onset osteoporosis. So how can you help her? Well, the number one issue that of patients that come to the music program is painful sex. And it's very interesting for me to hear each patient's journey through their cancer treatment and where these issues may have been brought up. But a lot of times patients will go through treatment, through chemotherapy. These young women get put into kind of this menopause and then a sustained menopause with the ovarian suppression. And they'll start having sex after treatment and say it feels like knives, and they're terrified. It's actually very, very scary for them. They think something's wrong with them. They think they're dying. And so that's probably the biggest issue that comes up. So the first thing I talk to patients about is, back to my GYN roots, is eliminating irritants. I tell patients, that skin is so delicate once the estrogen goes really low in your body. So you want to avoid anything with fragrances, parabens, any long name chemicals. I tell patients if you wouldn't put it in your eye, don't put it on your vulva. You want to avoid glycerin. And then I always tell patients the vagina doesn't need soap. Everyone thinks that the vagina needs soap, but it actually doesn't. And now douches are cleverly called feminine washes in the grocery store. And there's whole aisles dedicated to them. And I just want to go push the whole aisle over and have get so mad. So I always tell patients, water only. That means, trying to avoid sitting in bubble baths, even, fragrance, panty liners and tampons, detergents that you wash your underwear with. And then I also tell patients to sleep without any underwear because Gardnerella is an anaerobe. Gardnerella is related to BV. And so airtime can decrease Gardnerella. So that first is eliminate irritants. Second is moisturization. I separate it from lubricants. So I tell patients every day after showering, I start with single ingredient organic coconut oil because most patients already have it in their clinic, in their kitchen. Everything that's red in here is not safe with condoms, just so you know. Vitamin E suppositories are also available online. You can get them on Amazon, but the feedback I got on that is that they melt really quickly. And so patients have to run from the bathroom to the bed. But probably the best product out there, the non-hormonal, is these hyaluronic acid products, specifically Reverie, these by Bonafide suppositories. Restore by Good Clean Love is a great brand. And then you want to avoid petroleum-based products because they also degrade condoms. I do sometimes treat these patients with vaginal estrogen. I start out with non-hormonal options, but vaginal estrogen is the best treatment a lot of times. It's not contraindicated. There's observational data showing no increased risk of recurrence. And in patients who are having recurrent UTIs, this is a really good treatment for them. Sometimes, so anytime I'm going to start a patient on vaginal estrogen, I always talk to their medical oncologist. And sometimes I can convince them to maybe switch the patient to tamoxifen for a while, because the way I explain it to the patient is like tamoxifen like a shield for your breasts against any circulating estrogen, whereas AIs work by keeping your estrogen really, really low, like way lower than it's supposed to be in menopause. And so the changes that happen in the vagina are actually much worse than normal menopausal changes. And sometimes even by the time I see patients, if they've had these symptoms for a long time, like after like 7 years of ovarian suppression, the anatomy of the vagina has completely changed. It's not just dryness, it's that loss of elasticity, narrowing and shortening of the vagina. And so once we're at that point, really vaginal hormones really the only way to get them back to like functional aspect of sex. And so I'll talk about a vaginal hormone with dilators, which I'll tell you more about. Newer thing on the market is these vaginal androgens. There's an FDA approved product called Prosterone or Interosa. It's for painful sex. DHEA is aromatized probably in the, it works by endocrinology, and there's no increase in serum estradiol. It's totally safe in AI patients. And there's also compounded vaginal testosterone, which I have a trial for, but you just have to find a compounding pharmacy that you trust. I talk about lubes. I say every single time for the rest of your life, this is just how it's going to go. And I talk to patients about avoiding things like things with flavors, warming, water or silicone-based is safe. My go-to, I always tell patients, is Uber Lube. It's hypoallergenic. They're going to use an oil-based lube. Just make sure that they know that they can't use condoms. There's also some newer like CBD lubes on the market. I don't have like a professional opinion about them, but some patients seem to really like the concept. I just would always caution patients, be wary if you're someone who needs to take a urine drug test for work or something like that. Some of that CBD, there is THC in some of these products because the way they're regulated could theoretically be absorbed and change your urinalysis. You want to avoid long name chemicals in these, just like everything else. And then I really want to encourage you guys to start the discussion early, like right when the patient starts treatment, maybe not the first visit because there's a lot going on then, but starting some of these things like moisturization and using lubricants early and preparing patients, I think can really prevent some of the more severe sequelae. Also, it gives you a chance to validate their concerns, let them know they're not alone, so they're not scared. These problems are very, very common. Like 80% of breast cancer survivors have them. And obviously very common in GYN and other cancer survivors. Women who get chemotherapy for any reason in their 20s and 30s get put into a temporary or even permanent menopause. And it sounds like you guys are going to have a talk about premature ovarian failure coming up. And you also want to clarify misconceptions. Like women, depending on where they're from or how they were educated, they don't always know everything about their bodies. And they don't know, may not know the difference between the vulva and the vagina, which is something I learned that I needed to explain to everybody. And so it gives you a chance to kind of educate patients as well. These younger patients, sometimes they're going to be recommended for oophorectomy. I just want to, and I get referred some of these patients too for the GYN aspect of this surgery. So patients who don't have a BRCA mutation, we know that the decreases mortality if they have a BRCA mutation. The ones that don't, that just have an estrogen sensitive breast cancer, I wouldn't jump to just doing an oophorectomy. I would let them have their ovarian suppression for a while, because if they're absolutely miserable, you can stop their ovarian suppression. But if you take their ovaries out, there's no turning back and you can't give them hormones. The other thing is, I think once you do an oophorectomy, their symptoms are even more severe than when they're on ovarian suppression. And so I think I know that there is also a significant impact on long-term mortality. So it really does take a balanced discussion in coordination with her oncologist about what are the competing issues of mortality here, because women who have their ovaries removed in their 30s may have a cardiovascular event in their 50s, or may break their hip in their 50s. And these are things that we need to think about. So in patients who have non-estrogen sensitive cancers, so a 24-year-old with early stage squamous cell carcinoma of the cervix, she got a hysterectomy and chemoradiation. She reports painful sex and hot flashes since radiation. So The other second most common issue, and usually this goes hand in hand with dryness and low libido, is painful sex. So I always talk about starting the moisturization regimen early. Screen these patients for STDs, and you guys are probably going to talk about that, but sometimes herpes can show up as like vulvar pain, and subclinical chlamydia can be pelvic pain on deep thrusting. And so I always screen these patients. Even my like 80-year-old patients in music, I always ask them, I offer everyone a STD test. Do you want one? And half the time they're like, yes. So I offer it to everybody. Lubricants every time. Refer to pelvic floor physical therapy. Find one in your area. They're amazing. They can help patients with dilators. And then down here is the ONET. This is awesome. Patients love these. They're actually like bumpers for the penis. You place them on the penis so that it decreases penetration, the depth of penetration. And some patients have like written into the music Instagram and they're like obsessed with them. Some single dose macrobid can be helpful for postcoital UTIs. We try to avoid things like Cipro in these patients unless they need it for another reason. And then, so she's also having hot flashes. So systemic hormones are the best treatment for this. Cervical cancer actually isn't estrogen sensitive. You do want to talk to the GYN oncologist and just go through this with them, but you can start patients with squamous cell carcinoma of the cervix on systemic estrogen. And that even includes some ovarian cancers. Estrogen alone does not increase the risk of breast cancer. This is the long-term WHA trial data. If they still have a uterus, they also need to take a progestin, and that's for endometrial protection, because estrogen alone would cause the endometrium to increase the risk of hyperplasia. And giving these patients some estrogen back will not only make their lives better and decrease their symptoms, but decreases their cardiovascular risk, bone protection, and maybe even decreases their risk of dementia. So looking at the WHI trial data, of course, this didn't get as much media steam as the combined progestin plus estrogen increases the risk of breast cancer, but all-cause mortality is lower in these patients who got estrogen alone. And probably keeping patients with like a low level of estrogen instead of letting them be menopausal early and for a very long time probably does improve their overall mortality. And patients who got hormones also didn't have a change in their cancer-related mortality. So I'm not sure if you guys will be prescribing HRT, but I wanted to let you know a couple of tidbits of information that I've learned through the years. So in a newly menopausal patient who has a uterus, you just don't want to forget about that progestin. You can also look these guidelines up. And then for a progesterone, you want to opt for micronized progestins. They have a lower VTE risk and breast cancer risk. Transdermal estrogen is awesome. So patients don't need to take a pill. They can put the patch on once a week. You can start in a really low dose and it has a lower risk of VTE. Contraindications are things like unexplained vaginal bleeding, liver disease, ER positive breast and endometrial cancer, and thromboembolic disease. You have to warn patients that if they may have reactivation of their endometriosis or migraine headaches or fibroids. So just to set expectations. Non-hormonal options or newer options is this bazodoxifene with estrogen, and you actually don't need a progestin with that because this bazodoxifene is a SERM. It probably also protects against breast cancer, but it's a newer product, so I'd encourage you guys to look it up. Venlafaxine and oxybutynin are very effective for hot flashes. Gabapentin is not. Gabapentin is only effective at a dose of 900 milligrams a day. And this wasn't my patient, but I know of a patient who was started on 900 and got in a car accident. Like the gabapentin sedation is real. And it's not effective earlier than that. I always tell patients there's no benefit to this bioidentical hormones thing. There's issues with purity, efficacy, and titration based on salivary hormone tests, which seems to be how some naturopaths are titrating their meds. You want to taper them off if you have to stop them. And we always used to say lowest dose for the shortest period of time, but it's probably better to say appropriate dose, duration, and regimen. So you give this patient transdermal estrogen and you completely change her life. I actually had a patient like this, and she's like the biggest online proponent of the music program because she says she got like her life back. So a brief little bit about contraception. So the infertility message is oversold. like patients think they're infertile when they're not, especially these younger patients. So it's really important to have this conversation, as I'm sure you guys know. I always, as a gynecologist, try to avoid the condoms only plan, because condoms are not perfect use. Condom is effective, but no one does perfect use. And it's just like a fact of life. Patients also need reliable contraception during treatment and during the period of high risk relapse. Like if a patient becomes pregnant the year after getting treated for AML and she relapses, that is going to be an absolute disaster. So I always encourage patients, keep your IUDs in. I'll call the medical oncologist and be like, don't take her IUD out, even if it has progestin in there. Leave it in place, at least get them through like the first part of their treatment. We don't need to be pulling everyone's IUDs and having them get pregnant during treatment. It's a mess. Also, progestin IUDs decrease their bleeding during their periods. So if they're like anemic and thrombocytopenic, there's also the benefit for that. Don't forget to counsel them that contraception does not equal STD protection, because a lot of young women think that. These are good resources for you guys. You can find them on the Beyond the Pill at UCSF. And then the CDC has a medical eligibility criteria app, which I have on my phone. So if patients maybe are smokers and they're this age, can they get this kind of birth control? It's actually really, really a helpful app. And then lastly, I don't want to go over my time, but non-prescription tips for libido. So first, fix the atrophy and the genitourinary syndrome of menopause, which is actually the new term for atrophy, which is very sexy, or not at all. But it's like a change in architecture. It's not just dryness. So if you let these symptoms go on for a long time, their vagina is not going to even be functionally like a vagina anymore. And that means they can't have GYN exams. They can't get pelvic ultrasounds. The way I start is hormonal regimens, then I think about vaginal androgens, then go to vaginal estrogens. For medications, SSRIs will completely zap a patient's libido, like give them anorgasmia, like complete inability to have an orgasm. So bupropion has no sexual side effects. Beta blockers can zap libido. And then I'll talk to their medical oncologist about at least trying to switch them to tamoxifen, because sometimes that can be less symptomatic. Exercise is huge. And then I talk to patients about, and this was really hard for me when I started the music program, because like I was raised Catholic in South Texas and we never talked about this stuff. So I kind of always frame it like, oh, check out these cool, sexy podcasts. They're like designed by women, for women, all different kinds of things you can listen to, like sexy accents or these like stories. And patients are really into them. And then I've always more recently have been having a talk, or at least mentioning the concept of ethical porn and staying off of sites like YouPorn and Pornhub, because those are such terrible sites. And there's these really great ethical porn websites that are like porn designed by women for women. So I talk to them about communication and date night with their partner, and then sex positive podcasts like Sex with Emily. And also I think it would be good for you guys to listen to those podcasts too, because one of the things that I did was listen to how other people talk about these sensitive topics like masturbation and vibrators, etc. This is another, this is for finding a counselor. This is a sexual therapist, the AASECT website. You can find one close to you. Then these are the two pharmacologic options for women. Addy or flibanserin is a once daily pill, serotonin modulator, may be effective. Increases sexual encounters, 1 additional sexual encounter per month, which if you're going from 0 to 1 is a huge deal, but 5 to 6, maybe not so much. There's studies ongoing for patients on tamoxifen, because tamoxifen would make that flibanserin less, inhibits the metabolism, but the flibanserin doesn't make tamoxifen less effective. But they're involved in the same liver enzyme. Biggest side effect is dizziness. The black box warning for this a couple of years ago was not to drink on this. That was lifted. Patients can drink when they're taking this medication. If they just drank a lot that day, tell them not to take their pill. Both of these have pretty informative websites too. The new kid on the block is this Vyleesi or bremelanotide injection. It's an injection before sexual activity. I haven't gotten any patients to even consider this, because cancer patients don't want more injections. And it's not for patients with cardiac issues. There's this newer supplement that's actually based on research by this company, Bonafide. It basically, pine bark extract works like nitric oxide. It's on the Bonafide website, and I've looked up the studies and they are placebo controlled, and usually patients report improvement by 2 weeks. So I have used that. And then what I don't recommend, I don't recommend things like vaginal steaming, vaginal detox. I'm always telling patients like your vagina doesn't need a detox, no feminine washes, and like basically anything on the Goop website, I don't recommend. So that includes like jade eggs, which can make pelvic floor muscle dysfunction worse. I actually don't recommend the Mona Lisa laser for patients on ovarian suppression and AIs because their estrogen is so low that I think the healing is completely disrupted. That mucosa isn't able to heal. And the effects of these lasers are entirely dependent on normal healing and blood flow. So maybe patients who are able to take estrogen and vaginal estrogen and get the laser may do okay, but I've seen patients who have burns. Their anatomy is so distorted. I just can't imagine someone from a med spa being able to do this correctly. And it needs to be someone who's really familiar with all of the variations in anatomy, is how I would say that. And then I caution patients for these surgical cures because sometimes surgery can make it worse. These are some tips for other things that I tell patients. So acupuncture for bone pain, exercise, hot flashes, and then minoxidil or Rogaine or rosemary oil for hair loss, and then bimatoprost, which is Latisse for their eyelashes. And then for rashes, I refer to Derm, and just avoid over-the-counter benzoyl peroxide and salicylic acid. So, hold on. So in conclusion, start the conversation. Moisturization is every patient's friend. Check the ingredient list. Address these concerns early so they don't have severe sequelae. HRT is not always completely off the table. Don't forget about contraception. And these are some other resources, and specifically this book over here, this Ultimate Guide to Sex and Disability. I don't like that it has disability in the name, but I read this book in like one day. It gave me a lot of helpful tips on how to talk to patients who are experiencing these symptoms and talking to them about getting to know their body after surgery. And I thought it was really interesting, so I recommend it. So with that, I can take any questions.